I'd like to briefly introduce Jen Carter to you. She has she's a board certified specialist in swallowing and swallowing disorders. She's been doing this work for 25 years. She's now in private practice, and she's known locally and at the state and national level for presenting on all things swallowing disorder and other related topics. So with that, I'm going to turn this over to Jen. Jen has volunteered her time this evening to do this webinar. We're excited to have her. And so with that, Jen, please take it away.
All right. Thanks, Ed. So just to double check, let's see here, make sure everybody can see my screen. You should be good. All right. So thank you, Ed. I appreciate that. And I appreciate the opportunity to share my experiences with swallowing therapy with other clinicians. And so, oops, having a little bit of technical difficulty here. 1 second. There we go. Okay. So like Ed said, I have no financial disclosures. I'm volunteering tonight. And so a little bit about what we're going to be talking about tonight is the unique characteristics of dysphagia in head and neck cancer. What is myofascial release and manual therapy, and what is how myofascial release and manual therapy fit into dysphagia treatment? I'm going to talk about the latest evidence, as well as candidacy and precautions. And at the end, we'll talk about a case study and some of my patients' comments that they wanted to share with the webinar participants. So right now, we have a very diverse audience, is my understanding, on the call tonight. So we have many dysphagia clinicians and medical professionals. We also have patients and family members, as well as speech pathology students. So going to be talking to a wide range of levels of experience and levels of medical background, but hopefully tonight we'll have a little bit of something for everyone. So just to give you a little bit of a background about kind of the reason for wanting to do this is that, like Ed said, I do have a private practice in Denver and specialize in treating dysphagia. That's all I do, and I see quite a few patients who are survivors of head and neck cancer and have found this treatment modality to be particularly effective. And I know it's something that we talk a lot about in the field, but there's still a lot of questions. So really wanted to just kind of share my experiences and be able to answer questions about what I am seeing kind of just in the trenches in dysphagia therapy from day to day. So with regards to our diverse audience, Elizabeth, I believe we have a poll question to kind of see who might be on the call today. All right. I'm not hearing anything about the poll, so I'm going to keep going here. All right, so we're not going to do the poll, but that's okay.
Can you see the results on your screen?
Oh, beg your pardon?
Can you see the results on your screen?
Oh, I cannot, no.
Oh, okay. Let me read them to you. The results are in. It says 81% are SLPs. 7% of the audience is somebody who suffers from a swallowing disorder. We have 2% as other healthcare professionals, so MDs, nurses, PTs, or OTs, and then 11% of the audience are students learning about swallowing disorders.
Great. Thank you very much. All right. I will continue continue here. All right. So tonight I'm going to be talking about an overview of what myofascial release and manual therapy is and how it can be used in dysphagia treatment. But just to be very clear that this is not a how-to course, that this type of therapy is a very hands-on therapy, and so really is best learned from a course where you can learn it hands-on or from a skilled practitioner in person. So this will just be more of information to hopefully answer questions about what it is, how it can be used, what are some of the treatment outcomes that we're seeing. And at the end, I will have some resources for finding more information about how you can find a course, or if you are a patient, being able to find a person who provides this therapy. All right, so let's start off by talking about kind of the unique difficulty with swallowing that people who've had head and neck cancer experience. So radiation really affects people differently. So some people who have radiation for cancer treatment may only have like mild inflammation, complain of a sore throat, might have, some will have severe mouth and throat pain. They might require a feeding tube. But typically 4 to 6 weeks after radiation concludes, the swallowing is returning to normal. However, there's another group of patients, and these are the ones that we really primarily find ourselves working with, is that these patients will develop late effect complications, 3+ months after radiation. In my practice, I typically see patients that are several years post and have developed swallowing difficulty many years after their radiation. A lot of these patients will be able to swallow adequately for many years, and then they start to complain that they can't eat their usual diet. And the difficulty is due to increasing fibrosis in the radiated area. So what is fibrosis? It is an abnormal accumulation of scar-like tissue. It forms under the skin, in the connective tissue, around the muscles, between muscle fibers. And with head and neck cancer patients, it will replace swollen tissue during radiation treatment. And then, like I said, it can start years after and can continue to increase years after the treatment itself. So why does fibrosis happen to some patients? Well, the thinking is that wound healing is governed by a system in our body that instructs cells to fix damage by making new tissue. However, for some patients, after radiation treatment, this checks and balance of the system can become overwhelmed, and the cells will continue to abnormally make scar tissue. And it's suspected that this might be based on genetics, comorbidities, that some people may have a lower or higher threshold for developing this condition. It's really poorly understood, and more research is needed to truly understand the cause of onset about why some patients will develop debilitating fibrosis, whereas others may not. So since we do have many people on the call who are not dysphagia clinicians, just a little bit of some key concepts, swallowing 101, that you need to keep in mind when we're talking about these treatment modalities. So normal swallowing involves a lot of movement of muscles in the mouth and the throat. So there's a lot of contraction to create pressure to squeeze the food and liquids through the mouth and throat. And then there's also movement of structures that we actually close off and protect our windpipe. So the swallow is very dependent on movement in order to function properly. And so difficulty swallowing, which is the medical term for that is dysphagia, after radiation treatment. So the difficulty is going to vary, of course, depending on the location and the intensity of the cancer treatment. But bottom line, what we see with this population is reduced movement of muscles and structures. So the dysfunctions can include decreased tongue-based retraction, decreased hyolaryngeal excursion, and that's going to impact upper esophageal sphincter opening, epiglottis inversion, closure of the laryngeal vestibule, as well as pharyngeal constriction. And so the symptoms that result because of those dysfunctions is that we have reduced movement of food and liquid, which results in what speech pathologists term residue in the throat or the pharynx. So we see this residue kind of along the back of the tongue, the vallecula, the piriform sinuses, which are some of the cavities that are in the throat, as well as the walls of the pharynx. And then this residue can often result in aspiration. Aspiration is when food or liquid goes into the windpipe. And aspiration is common with this population. And many of these patients will have poor sensation, meaning that something will enter the airway and they may not be able to sense that something has entered the airway. The normal response would be that when we aspirate something, we should cough to clear that. But a lot of times patients who have had radiation treatment will have decreased sensation for this. And typically what we find is that liquids are easier to swallow than solids. They just don't require quite as much strength and movement in order to propel through the pharynx. So what causes dysphagia after radiation treatment? And so this is really the crux of why these treatment modalities we're talking about tonight work, is that muscles need to move in order to stay strong and to get strong. And so we have two factors that cause weakness after radiation. We have stiffness and reduced movement of the swallowing mechanism that's due to the fibrosis that we just talked about. So everything becomes locked down, it isn't able to move as much. And then those muscle fibers that are encased in that fibrotic tissue then become weak due to disuse atrophy. So let's talk a little bit about traditional swallowing therapy for this population. There was a study that was published last year by Langmore and colleagues, and the study was actually looking at the efficacy of electrical stimulation and exercise with patients who had dysphagia after head and neck cancer. It was 170 patients with moderate to severe dysphagia following treatment for head and neck cancer. And the two groups were randomized to therapy with active electrical stimulation or sham electrical stimulation. And I'm not going to necessarily go into the results of what they found with regard to the electrical stimulation, but there were some conclusions from this study that I think are really important. And that was that the traditional therapy that we're doing as speech pathologists with this population is neither group had appreciable improvements in their swallowing physiology. The author's discussion, and I quote, they said, for patients with head and neck cancer with moderate to severe dysphagia caused by radiation therapy, current behavioral therapies, what we're currently doing, are of limited help in reversing long-term dysphagia. Once post-irradiation dysphagia is well established, so once this dysphagia comes on in this irradiated tissue, current interventions are limited in reversing the decline of swallowing function. And so I think that that's important for us to know and to think about is, gosh, the therapy that we're currently doing isn't effective. What do we need to do to change that? And so that's what I want to talk about in this next section is, well, what can we do to treat this condition if what we're currently doing is not working? And so that's where I wanted to talk about these two treatment modalities. So myofascial release, what is that? It is a long-duration, deep stretch to mobilize adhesive tissue. And so we're going to talk about here what fascia is in just a second. But practitioners will use their knuckles or other tools to sink into the fascia and apply force to stretch this fascia. The fascia is what covers the muscles. And the goals of myofascial release therapy are to increase range of motion and restore optimal length, decrease pain, as what Ed was describing at the beginning of this presentation, and also to break up adhesions and improve function. So fascia is the connective tissue that surrounds everything in our body. it surrounds the muscles, it surrounds the nerves, the organs, the blood vessel. Its primary purpose is to be protective of those and to allow for, exchange of fluids and kind of maintaining that all of those things are working properly. But it can tighten and harden over time in response to trauma, such as radiation treatment. And so this trauma can result in restrictions that will cause pain and dysfunction in the motor performance. And so the myofascial release is working directly on this fascia to try to loosen this to allow for the muscle to properly move like it's supposed to. And then manual therapy. So the two of these really go hand in hand. When I am working with my patients, and I think other clinicians are doing this as well, is I'm doing a combination of myofascial release and manual therapy. So manual therapy is skilled passive movement of joints, so joint mobilization and manipulation, and passive movement of the soft tissue. And so manual therapy and swallowing therapy, we're going to be mobilizing and manipulating the hyoid bone, the hyolaryngeal complex, and soft tissue mobilization and massage of the oral and the pharyngeal muscles for swallowing. So the primary purposes of myofascial release manual therapy and dysphagia therapy are: one, to increase range of motion of the swallowing mechanism for improved swallowing function. Like I said, you have to be able to move in order to have good functioning, and also to allow for a more effective response to the swallowing exercise. So a muscle with limited range of motion can't be adequately exercised. Think back to that image I showed earlier of the arm in a cast. You wouldn't be able to exercise an arm when it's encased in the cast, and it's the same thing with muscles that are encased in fibrotic tissue. When I'm seeing my patients, first thing I think of is we need to loosen things up before I even start exercise, because that's what's going to be needed in order for the exercise to be effective. So I find that myofascial release manual therapy really primes the muscles to be better able to exercise. So what are the things that we can target with this? And we'll kind of go into detail about these. So the oral phase can work on improving mastication, bolus formation, transfer control, everything that kind of goes along with, with manipulating the bolus orally. In the pharyngeal phase, the actual closure of, better improved laryngeal valve closure, improved hyolaryngeal excursion, as well as pharyngeal constriction. So let's kind of talk about this a little bit. So mastication, working on the masseter, the medial pterygoids, and so really you can see in these images getting in there and just really mobilizing those muscles so that they can have improved range of motion and also will decrease pain as well. And so bolus formation, being able to target the orbicularis oris, the lips, and the buccinator. And so again, you can see by this picture that we're getting in there and just directly working on loosening up the fibrotic restrictions of the tissue of those muscles. And it really, like Ed said, can just, we can have a lot of pain when things are tight, when they're not supposed to be tight. And so by loosening that really can make it a lot more comfortable. And then we also can get improved range of motion. So I've used this with my patients, like trying to improve lip closure, so getting a better labial feel for better bolus formation and control. Having the buccinator just be more pliable to allow for better bolus formation. Further with bolus manipulation and transfer and control, that we can actually work directly on the extrinsic and intrinsic tongue muscles. This is something that easily you can have your patients work on, trying to improve lingual range of motion which also helps, not only helps with so many things related to what we do with the bolus orally, but also is a good precursor to being able to do lingual strengthening to further improve the swallow. So we can definitely target improving lingual range of motion. And then hyolaryngeal excursion, this is probably the area that I target the most with my patients, is really getting in there and working on the suprahyoid muscles, infrahyoid muscles. These two images, just showing some different techniques that can be used for working on that and just really targeting the tight areas and improving range of motion. And then laryngeal valving. So doing laryngeal manipulation, cricothyroid stretch, of being able to get all of those structures to be able to better valve and for better airway closure, airway protection. So just kind of getting all of the ligaments and everything between those structures nice and loose so that they can move better. And then pharyngeal constriction. So obviously can't, actually get inside, somebody's throat to be able to stretch the pharyngeal constrictor from a 3D angle. But when we think about the pharyngeal constrictors, that like here's the middle pharyngeal constrictor, which connects to the hyoid bone. And then we have the inferior pharyngeal constrictor connecting to the thyroid and the cricoid cartilage. So we can manipulate the hyoid bone, thyroid, and cricoid cartilages and stretch those to allow for better movement of the muscles that they are attached to. There are also additional target areas, so beyond of what we think of as speech pathologists with the muscles that we specifically target for oropharyngeal dysphagia, is that a person who is in better posture, that they are going to also have better swallowing function. It's a concept that we really at least I have learned from my PT colleagues, is that if you have the blocks of the body better stacked, better posture is going to just create better functioning. So some of these other areas that can be targeted, they can be addressed by either physical therapy or massage therapy, or some of us speech pathologists, not myself, have extended training to kind of work beyond the oropharyngeal area. So this might include cervical, like the mobilization, like the posterior neck, working on thoracic mobilization for the trunk, posterior cervical muscles, and the abdominal wall and the diaphragm, which can also, of course, help with breath support for good cough strength as well. So a lot of times what I will do is I will be working with a patient and I will be really targeting the oral and pharyngeal muscles, and then I will refer for other areas of tightness to PT and massage therapy colleagues that I have. So it can be done kind of either way. So some common questions that come up is sometimes people ask, what about lymphedema therapy? How is this different than that? Is this something that interferes with lymphedema therapy? So lymphedema is swelling that is caused by lymphatic system blockage. And so management of lymphedema includes manual lymph drainage. And this is gentle massage to redirect lymph. And so actually, manual lymph drainage and myofascial release are compatible when a patient has both edema and fibrosis. So they have both the swelling and the tightness. Because sometimes the tissue may be so firm and fibrotic in a patient who's had radiation that the skin cannot even be moved well enough to do the manual lymph drainage. And so we can do the myofascial release techniques first to, again, kind of soften and loosen the tissue prior to the manual lymph drainage. So yet another way that we can prime the system for the therapy that a patient needs. Another thing that sometimes are asked about is circumlaryngeal massage. How is myofascial release manual therapy similar to that? Well, circumlaryngeal massage is a part of voice therapy and targets excess laryngeal muscle tension. So the areas that I don't do circumlaryngeal massage, I don't do voice therapy, but the target areas are very similar to those that we're addressing in dysphagia therapy. So the horns of the hyoid, thyrohyoid space, posterior border of the thyroid, medial lateral suprahyoid muscles, those are the muscles of the throat. So working on those same areas that I just talked about with the myofascial release. The difference is that with myofascial release and manual therapy is that we're targeting fibrotic tissue versus circumlaryngeal massage is targeting tension. So what we're targeting is different, but certainly kind of the same areas of treatment. All right, so let's talk a little bit about evidence and research. And I actually presented on this topic of myofascial release manual therapy at ASHA in 2015, and am really excited that this section of the presentation has certainly updated in the last few years, that we're starting to get some research on this topic. So if we think about evidence-based practice, which involves, published research, clinician experience, and patient experience, that with regard to myofascial release and manual therapy in dysphagia, that there has been limited research thus far. Like I said, it's emerging, but we're still, could always use more. And that up to this point, evidence has been primarily the clinician experience and the patient experience. But I'll share with you some research that has been done. So in general, myofascial release manual therapy, well supported in the physical therapy and massage therapy literature, as a lot of the therapies that we've kind of started adopting in speech pathology were done by our other rehab colleagues first. And as I just mentioned, there definitely has been evidence about positive effects of the laryngeal massage or the laryngeal manual therapy with muscle tension dysphonia. So we have had that previously. A study that was published in 2009 looking at laryngectomy patients. So these were 95% who had had radiation therapy, and after one myofascial release session, they demonstrated a decrease in excessive esophageal pressure, which improved their ability to produce esophageal speech. The patients made comments saying, "I can speak more easily. I feel relaxed." So this was another early study that was done on patients who'd had radiation, showing that some positive effects. So in 2016, a study was published looking at manual therapy during radiation for head and neck cancer. So this was, like I said, certainly the first study that I'm aware of that they were actually looking at the use of this therapy in conjunction with radiation therapy. It was a very small study size. There were 5 patients, but a lot of times, initial research, we start small and build from there. And so the outcome measures that the authors were looking at pain before, during, and after manual therapy, and subjectively measuring range of motion. So the patients were attending 4 to 7 once-weekly manual therapy sessions during radiation, and the target areas were treated by both physical therapy and speech pathologists. So very similar to the breakdown that I had mentioned earlier about what speech pathologists treat and what physical therapists treat. And so these patients were also doing a self-administered home program 10 minutes a day. And this is pretty typical to what I do, that I see my patients maybe once a week and have them doing a home program on a daily basis. Okay. So what were the outcome measures? So with regard to pain, all of the patients felt that the manual therapy lessened their throat pain. And the authors really felt like this was significant, because that had been one of the concerns with doing this during radiation treatment, is that it would be too painful for patients to have this treatment. And actually, none of the patients experienced an increase in their pain. So as far as range of motion, they were looking at cervical range of motion, anterior neck mobility, hyoid pliability, how well that hyoid bone is able to move, and then the thyrohyoid base. And so the improvements were positive, but they were inconsistent. So they might have a couple of patients that improved in one area, but not the other. So it wasn't a real consistent improvement, but they were positive findings. And again, like I said, it was a small study group. But one of the things that the authors pointed out is that having no change or slight increases in mobility is actually promising, because it's commonly thought that tissue and joint movement decrease in most patients undergoing radiation. So the fact that this study, if the patients didn't see any worsening of their mobility, in fact, even making some slight increases, that would actually be very promising, since usually the opposite is what is experienced. And so, again, between that and the patients having a lessening of their pain, I think that this is a very promising study. And so then the authors said that their discussion, that they said that this has the potential to reduce localized pain and mitigate contractile tensions, inflammation, hypoxia, all of which are implicated in aberrant wound healing and long-term fibrosis and dysphagia. And since there are really no other treatments, rehab behavioral or pharmacological, that are capable of targeting these things, the potential effect of manual therapy is of great interest. Oops, going the wrong way. There we go. All right, and so another study, and this is actually unpublished, hot off the press, a study that was done at MD Anderson and recently presented at a conference in October, but it was looking at the integration of manual therapy into a speech and swallowing rehab program for head and neck cancer. And I believe that some of the authors may actually be on this call tonight, so I appreciate them sharing their information with me. And the objective of this research that they were doing was to describe the early response to an adjunct manual therapy program in a speech and swallowing rehab setting for patients with head and neck cancer. So this was 15 patients, and a little bit different than the last study I mentioned, in that these patients were an average of 8 years post-treatment that were referred for palpable fibrosis, lymphedema, and dysphagia. And the patients had all had radiation therapy, either with or without chemotherapy and surgery. So the outcome measures that they were looking at, the primary outcome measure was a change in cervical range of motion, and the secondary measure was swallowing change in patient perception. And the preliminary findings are that all the patients improved with their range of motion, and the patients also made functional gains in swallowing, airway, voice, and patient perception. Excuse me. And so, again, this is an unpublished study, but certainly is promising, showing that we're starting to see a trend of really positive outcomes with these treatment modalities. So I wanted to share a little bit, kind of add to the research what my own experience has been. So what I have found is that myofascial release manual therapy is only one aspect of the treatment. I feel like we still have to strengthen as well as improve movement. So we unlock the muscles with this treatment, but the muscles are still weak from disuse atrophy. So what I will do is I will add exercise when range of motion is improved. I'm instructing my patients on self-myofascial release manual therapy from day one. That is something that they are learning to be able to do themselves. And part of my therapy is my patients will transition to the patient doing most of that work independently between sessions. However, some people need more coaching than others, and I might have some patients for whom that we do this together for quite a period of time. So I find that I've been doing the manual therapy myofascial release performed primarily in a seated upright position, which is what you saw in most of those photos. The swallowing mechanism is aligned in that position in the way that it will be used for swallowing. So I find that that is the best way to target it, is kind of in the way that the system is going to be used. However, supine, as you did see in one of the photos, is sometimes useful for trying to increase mobilization. So occasionally I will do that. But bottom line is not one size fits all. This is a treatment that is very individualized to each patient, because each patient is so unique depending on, how much fibrosis they have, where the fibrosis is occurring, what their dysphagia symptoms are. So even though there can be a lot of similarities with this group, I find the therapy is very individualized. So just a sample treatment plan of what this looks like, and I share this to kind of give you a picture of how does this fit into what we currently do for swallowing therapy. So maybe it's swallowing therapy 2 times a week for 8 to 10 weeks, and I see outpatients, so it's kind of based on an outpatient model. So 8 to 10 weeks to increase tongue-based retraction, hyolaryngeal excursion for improved airway protection and pharyngeal bolus clearance. The treatment is going to include the following. And so I'll say it's going to include manual therapy to increase hyolaryngeal range of motion to allow for improved hyolaryngeal excursion. The patient will be instructed on a home stretching massage program to complete between sessions. Therapy will also include home swallowing exercise program consisting of, and then I list several of the common swallowing exercises that we would do for hyolaryngeal excursion and tongue-based retraction. So you can see it's just a part of therapy with the ultimate goal of improving the function of tongue-based retraction, hyolaryngeal excursion, whatever the dysfunction is. Another common question is certification or licensure in myofascial release manual therapy required? No, it is not required. However, as we speech pathologists know from the ASHA Code of Ethics, is that we really should only engage in those aspects of our profession for which we have enough professional practice and competence, considering our certification status, education, training, and experience. So no, a formal certification is not required, but certainly you need to have some training on this before doing it, just so that you are practicing within your competence. Some precautions for doing these modalities. So osteoradionecrosis, so bones being very fragile, you would want to be very careful around any necrotic bones, carotid stents, skin hypersensitivity, patient who's on anticoagulants, you would just want to be careful of bruising, be cautious of uncontrolled high blood pressure, maybe you're paying attention to what the surgical history is. So these are all just precautions that make sense. And then as far as contraindications, we would not do this treatment directly over an active tumor, localized infection, or cellulitis. We certainly would not do this over a fractured hyoid or an open wound, or if there's recent surgery with sutures and staples. So the precautions and contraindications certainly make sense. Home program. Patients, I feel, must do daily home program between sessions. And a lot of times I will have patients that maybe they don't have the dexterity to be able to do self-massage themselves. A family member can certainly be trained. I have trained many family members to be able to do this. After radiation, that fibrotic tissue, it wants to tighten up quickly. And so sometimes in the beginning especially, we might take 2 steps forward where we knock things down and get things looser, only to have it start tightening up a little bit more, 1 step back. But if you do 2 steps forward, 1 step back, 2 steps forward, 1 step back long enough, you can eventually get to a point where you're getting ahead of the tightness. My patients tell me, and I have certainly seen, following them long term, that they have to continue this to kind of stay ahead of returning tightness. So the way I think about it is, if we were to do some sort of exercise to get stronger, you have to keep doing exercise in order to maintain the strength. And so it's similar to that. Once improved pliability is achieved, it becomes much easier to maintain and easier to restore than at the onset of treatment. So my patients find that initially maybe they have to do a home program, maybe it's lasting 20 minutes. After a period of time, it's much easier to maintain. We've gotten things looser, and they can maintain it being looser with much less time, and maybe not even on a daily basis. A picture of one of my patients kind of demonstrating how he was able to do self-massage. He's been very successful with it. So who are the good candidates? Good candidates are, I would say, patients who are going to be dedicated and willing to do a home program on a regular basis. Another thing that would make sense is that if the patient has a functional swallow after their cancer treatment, but before the fascial restrictions, meaning that there wasn't some sort of surgery that happened that occurred, that was the cause of the dysphagia, that their swallow was actually just fine until the fascial restrictions started developing, until the fibrotic tissue started settling in. Those patients just have less to deal with, and so we're just kind of trying to restore that one aspect, and that tends to work well. And then with everything in medicine, the less severe somebody is, the easier it is going to be to treat. So my patients who have mild, moderate levels of severity will make a better outcome than my patients who have severe limitations. But I do want to point out that that is not to say that severe patients can't make some gains. And very often with this, that sometimes just a little bit of improvement can really make a big difference as far as quality of life, level of pain, ease of being able to swallow saliva. So even though the severe patients aren't as necessarily going to make as great of progress in the end, they typically can make some gains. So to learn more about this, I would recommend that for clinicians that there are several myofascial release courses that are out there, and I have the reference in an upcoming slide for courses that are geared toward swallowing. So rather than just like a PT type myofascial release approach, rather than looking at this specifically for swallowing. My PT colleagues that I've worked with before I was trained in myofascial release, if I asked for their assistance, they typically were not necessarily jumping in there looking at the same muscles that I wanted to target from a swallowing standpoint. So I think that courses that are more geared toward those specific muscles are probably going to be your best bet. Patients that, ask your swallowing therapist for guidance in a home program, and they can determine who in your area might be able to help with that. But I would like to emphasize that do-it-yourself training is not recommended. There are a lot of structures in the throat that require caution. We've got the carotid artery, we've got blood pressure and heart rate regulators. Just don't want to be just jumping in there and start moving things around and really pressing on things really, really hard. And not to mention the fact that therapy should be more targeted than that. We should need to be targeting the specific areas that are causing dysfunction. So don't recommend do-it-yourself training. Other options are available. So two of the courses that I was able to find, this is certainly not an exhaustive list, but these are two courses that do offer a myofascial release course that is geared toward swallowing. And for patients who are looking for providers, two resources. So one is there are a couple of registries of clinicians who have taken a myofascial release course and reportedly offer the therapy. I have to say that doesn't validate their skill level or their experience. This is merely, these are people who took these courses and they are listed. So, that at least gives you a start of some place to look. Another option that would probably be good would be you can also find a board-certified specialist in swallowing. You can search on this website also by zip code, and when you come up with a list of providers in your state or near your zip code, it will say whether those providers have head and neck cancer experience. So then you could find one of those clinicians and ask them if they offer this treatment. All right, so let's look at a case study together. All right, so this was a patient of mine who's 65-year-old male. He had base of tongue squamous cell carcinoma. He was treated with radiation and chemo. He did not have surgery. He reported no difficulty with swallowing for 10 years. And then 11 years after his treatment, he was on a liquid diet. He didn't have a feeding tube, but he did have occasional aspiration. He was not able to eat any solid food. So the initial modified barium swallow study showed that he had moderate to severe dysphagia. He had reduced tongue range of motion and tongue base of traction. Anybody familiar with the MBS-IMP, he had a wide column between his tongue base and his posterior pharyngeal wall, so that was pretty impaired. He had decreased hyolaryngeal excursion. He had only partial laryngeal vestibule closure, so that is his airway closure, minimal to absent anterior hyoid excursion. He had absent epiglottic inversion and decreased upper esophageal sphincter opening, as well as reduced pharyngeal constriction. So pretty typical group of dysfunction. His symptoms, he had laryngeal penetration of thin liquid and puree during the swallow. He had significant pharyngeal residue throughout his pharynx, his throat, which was worse with thicker consistencies. He did not have any aspiration during the modified, but he was certainly at risk of aspirating the residue. EAT-10, which is a swallowing self-assessment tool, he scored 31 out of 40. A higher score, the closer you are to 40, the higher score indicates worse functioning. So this is an image, and the arrows are pointing at the residue in his vallecula and his piriform sinus after the swallow with a bite of puree. Take a look at a post image here in a minute, so kind of look at that. All right, so swallowing therapy, and I instructed him on myofascial release, and I also gave him some throat and lingual stretches. So we did 2 sessions that were completely dedicated to myofascial release and training him on home program. He picked it up very quickly and was then able to complete the program daily between sessions. I then followed him for an additional 14 sessions, so depending on the week, we aimed for twice a week, but sometimes it was just once a week. And so I would do the myofascial release prior to doing PO trials with him. PO trials meaning I was giving him something to eat. And so I would loosen things up before he would be eating and drinking. And this is actually a strategy that a lot of my patients, my long-term patients, will use, is that they, after discharge, will do their self-massage before meals, because they find that that just little bit of extra loosening up right before they eat can make a difference. So he progressed from swallowing thin liquid that we gradually increased the viscosity of what he was able to swallow, then thin puree, thick puree, and eventually a cookie. He was doing a home swallowing exercise program between sessions, so he was doing the self-massage, he was doing the lingual stretching like I showed you earlier. He was also doing exercises to target hyolaryngeal excursion and tongue-based retraction. So the repeat modified barium swallow study, we noted that there was improved laryngeal vestibule closure. So it did not completely eliminate penetration, but he had less depth and decreased quantity of laryngeal penetration. He also had improved upper esophageal sphincter opening, which was evident that by having less residue in the piriform sinuses. He had improved pharyngeal constriction. He had a slight improvement in tongue-based retraction. Epiglottic inversion remained absent. And that is actually something that I typically see. I can see a lot of improvements in functioning, but very often that epiglottis just does not move, even after all the treatment. And it makes me wonder if we were able to do myofascial release actually inside and around the epiglottis, inside a person's throat, if we might be able to get that epiglottis to move a little bit better. But that is one thing that usually does not change in my treatment that I see with patients. And so you can see this post-treatment image. He was not doing a chin tuck. I think that he was just seated a little bit differently that day. And you look at the quantity of the residue in the vallecula and piriform sinuses and see that he did have pretty significant decrease in quantity of residue. So my patient moving forward, after therapy, I recommended that he continue with the myofascial release and the lingual stretches and the exercises to maintain the gains that he had made. He said to me, my swallowing feels more normal, and he was also eating foods in addition to liquids. At discharge, he reported that he ate a wider variety of solid foods than he did when I first met him, and his EAT-10 self-assessment score was a 13 out of 40 at discharge, whereas he was initially a 31 out of 40. So really made some nice gains. And I spoke with some of my patients who have been successful in using this technique, and I told them I was doing this webinar, and I said, what would you like to tell people who are attending the webinar? So one of my patients said, the massage therapy reduces the swelling and loosens the muscles in my neck, making it possible for me to swallow. Another one of my patients said, the exercises and deep tissue massage techniques Jen taught me have helped immensely. Things go down way better, or much better, when I do the massage consistently. The deep tissue massage loosened my muscles, enabling me to swallow much easier. The overall sessions gave me the confidence to explore a new menu of solids and liquids. And finally, one of my patients said, I notice a difference in swallowing when I don't do my massage. So I think that that was really kind of the take home, is that they could really feel a difference. And if I was going to say kind of in a nutshell, what is the greatest benefit that I see with this treatment, is that my patients say the swallowing is easier. And that, like one of my patients here commented, gives them confidence to try other things in therapy. So that is probably the one thing that I do see consistently in gains with my patients, is an ease in swallowing. So in conclusion, I think that myofascial release manual therapy is a very promising modality for helping to restore range of motion and movement in the swallowing mechanism after head and neck cancer treatment. I wonder, based on previous research that's been done showing our treatment to not be particularly effective with this population, is this modality the key that could make swallowing therapy more effective with our patients? I don't know. I feel like I have certainly found that. That's just been my clinical experience. But we certainly need more research to know more about, what is the effective protocol and techniques? What are the typical outcome measures, as well as the long-term benefits? So at this point, I would like to open it up for questions. Elizabeth, did we get any questions? Anybody have any questions?
Yeah.
Jen, we have a number of questions.
Okay.
But I'd like to supplement what you've said, which means I'd like to try to share my laptop screen.
Okay.
So you talked quite a bit about exercises, and for those who are not familiar with our website, we have a section on exercises, and I'm just trying to see it at the same time you all are seeing it. But we encourage patients to use this in conjunction with their therapists. I think there are 10 or 11 exercises here, but you mentioned some of these in your talk, and most of these have videos that go along with them. So you can go to our website, go to patients and caregivers swallowing exercises, and then see the exercises. And toward the bottom, somewhere around here, you can actually print out a 2-page template that says how many, the exercise name, the description, how many reps you should do, the time, the rest interval. And this is something that you as a therapist would work with your patient to come up with that time between visits to help them with their exercise routine. So I just wanted to supplement really all the terrific advice and experience you were giving with some tools that we have to help patients.
Great.
So there were a number of questions that came in, and I'll start at the top. I'm a family member who is 17 years old and is beginning radiation treatment for melanoma, head and neck cancer with surgical intervention. Do you suspect he would require dysphagia treatment and begin preventive measures? And then they note that this age group is very small for head and neck cancer.
You know, it's always hard for me to answer clinical questions without like actually meeting a person or knowing the whole medical history, but I think it's certainly worth inquiring about and kind of maybe asking the medical team that's treating her, you know, about that possibility and asking if, you know, a consult to a speech pathologist could be appropriate, because I think that, you know, at the very least, just having a speech pathologist to then take a look at the whole situation and answer that question for you would probably be well advised.
And I'd like to just echo, it's so important. Each person is really so unique in how they've been compromised that one size does not fit all.
Exactly.
Okay, another question. In our head and neck center program, I see patients who start having problems with swallowing during the radiation treatment. Is it helpful to start this during radiation treatment rather than after? And I think you did touch on some of this.
Right. I think that we have one very small study that can show that, you know, it certainly, you know, has been helpful, you know, for a limited number of patients. But, you know, we need more information on that. But I think that it certainly is promising in that direction. I think that that would be something to talk about with the treatment team, and maybe, you know, if there is a concern about patients having pain and not being able to tolerate it, and, you know, it's such a small sample size that there could be patients for whom that, you know, don't tolerate it. But I think that I provide the reference for that study is maybe sharing that with your treatment team and asking them if this would be something to try. Excuse me.
And then this one, this question is very similar to that, but it has a little kicker at the end. Can you speak about MFR during radiation treatment and who would be a good candidate? And then the kicker is, especially since an active tumor is a contraindication.
Yes, yes, I think that that is a very good point. And when we're working over an active tumor, it's kind of knowing the location of where that tumor is. I mean, the whole area can be getting radiation, but is that where you're actually, where the tumor is that where you're going to actually be doing your treatment? So you wouldn't, like if the tumor was very deep and not going to be reachable by what the techniques you're doing, then I don't think that that's necessarily a contraindication. You just don't want to be working right on top of a tumor. As far as which patients are good candidates, the ones that are going through radiation treatment, I think that that is an excellent question that we don't know yet. You know, this study, like I said, you know, 5 patients participated, and they were all going through radiation treatment, and they all tolerated it well. But as far as like, well, how do we better define that population? I think that this is like a good entry-level study for us to then build more information on. But that's an excellent question. I don't think we know the answer to that yet.
You also did touch on this. are you doing traditional exercises along with MFR?
Absolutely, yes. I really can't think of a single patient that I've treated that it was just the myofascial release and manual therapy. Sometimes if the level of stiffness is really tremendous, that will be all I'm doing for a while, because it feels like if nothing's moving, why am I going to give them exercises? We need to get things moving first. And that's a rather subjective kind of determination. But if I can't feel good movement during hyolaryngeal excursion, they're certainly not going to be able to exercise those muscles. But eventually, all patients will get exercises in conjunction with it. Absolutely.
Okay. I'm going to butcher this, but here goes. Can you comment on the use of MFR/MT on patients with light dysphagia who also have flaccidity/atrophy related to cranial neuropathy, such as hydroglossal palsy?
Wow, they got a lot going on there.
Yes.
So, yeah. And again, it's difficult to answer specific patient questions without actually seeing the patient and their full history. But I think that if you kind of break things down to, okay, where is stiffness impacting everything that's going on here? And you mentioned, I heard atrophy in there. So, if the stiffness is affecting those muscles, definitely working on that to try to help that muscle be able to rehabilitate. And then when you have cranial nerve involvement, I mean, that's not necessarily going to respond to this treatment, but this is certainly a part of the therapy. It would never be like the entire therapy, but I think that when you see stiffness, adding this to that stiffness makes sense and can at least knock down that piece of the what you're dealing with when you've got a lot going on.
Okay. Have you considered trailing kinesio tape to address the fibrosis?
I have not. I attended Brad Smith's lymphedema for head and neck cancer patients the course a couple of months ago, and we talked about using kinesio tape for helping with redirecting lymphatic, encouraging lymph drainage. But I don't know if it would be aggressive enough for the fibrotic tissue. It would kind of depend on the patient, but my gut feeling is probably that might be great for as part of lymphedema therapy, but I don't know that it would be a powerful enough force for myofascial release manual therapy.
Okay. There's 3 or 4 more.
Sure.
Do you find a difference in using MFR with patients who have had primary chemoradiation versus patients with primary surgery and adjunct chemoradiation?
I think that it kind of depends on how much each of those treatments is impacting and causing dysfunction. I think that if the patient had radiation either with or without surgery, I mean, the patient who had things altered surgically, there's just more going on. It's going to be a more complex system that you're trying to rehabilitate. But I think that doesn't necessarily mean that they're going to be worse. I don't know if this is an upcoming question, but sometimes I'll get asked if I use this treatment with any other patients, and I do actually use this with some patients who have had some sort of anterior neck surgery and no radiation. And those patients do, like the anterior cervical fusion, thyroidectomy, and those patients do respond when it's surgery alone much faster than when you add the radiation to it. But I think if you have radiation versus radiation and surgery, if I'm understanding the question correctly, I think they could both be pretty equally complicated because of the radiation.
Okay. What do you think about another form of body work, Rolfing, or another term for this, structural integration in terms of working with the fascia?
That's interesting. I am certainly not trained in Rolfing, but I'm familiar with it. That Rolfing is a technique that kind of works on the entire body. And I think that that slide that I showed with all the blocks like stacked on one another is kind of a Rolfing, that's one of the concepts of Rolfing. And so I could see that Rolfing could be beneficial from the standpoint of, just like I was saying, if you stack everything in better alignment, that can improve functioning, and swallowing is kind of on the top of this stack of all these blocks that make up our body. So, I mean, it certainly stands to reason that that could be helpful. So I don't know if Rolfers would work specifically on the muscles for swallowing. I don't know how specific they get to like supra and infrahyoid muscles. That I'm not familiar with, because that would definitely need to be addressed, is these specific muscles that are causing the dysfunction.
Okay. I'm going to paraphrase this.
Okay.
But how do you use the results of MBS to target the therapy? So what do you see in the MBS that allows you to target the muscles?
I'm not sure I'm following the question.
Okay, let me not paraphrase as much.
Okay.
Do you use the MBS to infer restrictions? Do you assess clinically, manually, target all accessible muscle groups for all patients, or use other factors?
Okay. If I've understood the answer correctly, is it's going to be a combination of, of course, the modified barium swallow study or a FEES to be able to, look at what we cannot see from the outside. But a lot of it is feeling what's going on, being able to feel where the areas of tightness are. Because, if we saw on a modified barium swallow study, if a patient had decreased hyolaryngeal excursion, is that decreased hyolaryngeal excursion due to weakness, or is it due to stiffness? Well, then you'd have to put your hands on the patient to really kind of feel what's going on, but it's good to kind of know what the impact is too, just from the modified barium swallow study. So it's definitely, I think, a combination of both, but a lot of kind of deciding what to target, in addition to my evaluation report, is where am I going to do manual therapy is what I'm feeling.
Okay. Two more questions.
Okay.
What is the typical reaction of physicians to this therapy approach, considering the limited evidence?
I mean, not to be flippant, but I think if the physicians that I've dealt with are great, you're doing something that makes my patient feel better and is helping their swallowing get better, that's awesome. So I haven't met any, I haven't met resistance on that with the physicians that I work with. They're just happy at the satisfied patient and the improved swallowing outcomes.
Okay.
So.
All physicians should be like that, right?
Yeah, right.
And then, lastly, for for thyroidectomy patients, does MFR ever help a patient whose sitting upper vocal range decreases post-thyroidectomy?
I have actually been seeing quite a few patients post-thyroidectomy, and this has really been beneficial for that patient population. I've been working with an endocrinology surgeon for the last year, and she had actually told me when we met that that difficulty swallowing is the #1 complaint that her patients have after their surgery. And so these patients respond really well. Just a couple of sessions. I've had a few patients, kind of like Ed, that I just needed one session and to loosen things up. So that, I think, is there's a tremendous amount of potential with that population.
Jen, that ends our questions. I want to thank you so much for this evening.
Absolutely.